In basis, since the field has been moving to more to what we call a chemo-free, or which really means that moving away from cytotoxic chemotherapeutic drugs, we thought we could, potentially, try to expand on the knowledge of that in mantle cell lymphoma. So based on the original study that was done from the Cornell group, where they treated patients with R2, this is a study that came out, I think, almost 9 years ago now. They treated patients who were thought to be ineligible for an autologous stem cell transplantation or who declined participation in a stem cell transplantation. They were given R2 for a year, subsequently transitioned to maintenance. With a 5-year update, they showed very good progression-free survival. So we use that as a backbone to see if we can hopefully augment that study with the addition of the BCL2 inhibitor, Venetoclax. Venetoclax was originally studied in a study by Matt Davids. He was a PI of the study, should I say, where they looked at it in relapsed refractory disease in multiple subsets of lymphoma. They did have a very good response rate in patients with mantle cell lymphoma. I'll bet those patients were BTK naive. So it wasn't really a true patient population for what we would see nowadays in clinical practice, but it did show that mantle cell lymphoma was sensitive, especially in the BTK naive population, to Venetoclax. So because of some preclinical data showing synergy between the two drugs, we thought it would be a good partner with R2, mainly augmenting lenalidomide, to see if we could, prove that this combination was safe. That was the main purpose of the study. But secondarily, we wanted to look at a couple of key endpoints. One was time to best response. One was the overall response rate. And we also want to look at minimal residual disease. So we use an assay by Adaptive Biotech that uses a next generation sequencing to look for molecular evidence of the lymphoma in the peripheral blood of patients as an augment to radiographic response. So what we want to see is if we could actually get very good radiographic remission, and also if we can get what we consider molecular remission in these patients. So the adaptive assay looks for the presence of cancer cells to the 10 to the negative 6th in peripheral blood. So that was the purpose of the study. So when we started the study in December of 2018, our goal was to try to give patients a year of induction, which mirrored exactly the study from Cornell, and then transition patients to maintenance. We anticipated the maintenance portion to be a continual de-escalation of therapy to the point where the patients would eventually come off all treatment. So they would get a year of Venetoclax, 2 years of lenalidomide, and 3 years of Rituximab, and then they would stop all treatment. So we thought having a finite treatment period would be very, very important versus having them to be continually on any sort of oral medication. So the good thing we saw with the treatment response is that we did see that we had very good responses in some heavily pretreated patients, or not heavily pretreated, patients with heavy disease burdens. So we did not want to shortchange the treatment. Either it was going to work in all patients or it wasn't. So we enrolled all comers, irrespective of stage, disease bulk, morphology, or high-risk characteristics. And we purposely evaluated for p53 deletions and mutations in all these patients. What we saw from the study is that other than patients that had a p53 mutation, we saw that all other risk factors did not seem to impact response. As we had 3 patients who did not respond to treatment as the others have, and those 3 patients all had p53 mutations. So in that population, we had 1 patient that did get a complete remission, but had a short remission period and relapsed by month 9. Another patient had a partial response, but relapsed again by month 9. And 1 person did not respond at all. Of the other 25 patients, all those patients did have a response to treatment. And those who have completed at least 6 months of treatment, all those patients appear to be in a complete remission by PET-CT. And a fair number of those patients are in molecular remission. I think of the patients who've completed at least a year of therapy, we have only 1 patient who has some disease detected by molecular testing. And that test result is what we would call equivocal, meaning it's not negative, but it's not truly positive. So we don't really know what that means for that 1 patient. All the other patients will be considered negative. So far, all the patients who we've obtained an MRD negative result on, none of those patients have lost their remission. And they all remain on treatment and in remission at this current point. The one thing that we've noted from the study, and that obviously has allowed us to make some future plans, is that, again, we did not have great responses in those p53 mutated patients. So with the planned expansion of the study that we have ongoing, we plan to expand the study to enroll another 50 patients. We are going to exclude those patients with p53 mutations with the hope of getting a truer sense of how the response rate is in those patients with those being excluded. For those high-risk patients, like those with p53, we are planning a separate study that will utilize a bispecific antibody in conjunction with the Venetoclax and Lenalidomide backbone to see if we could actually make some improved responses in that patient population. So I think what we've seen and what's important is that we see that you can get good responses. You can get, hopefully, what we hope will turn out to be durable responses without the use of cytotoxic chemotherapy drugs, without the use of a stem cell transplantation. But, I still think for these high-risk patients, which I will point out don't benefit from a stem cell transplant, at least is what we know, that we still have some work to do as far as finding an appropriate treatment regimen for those patients. So that is the sort of the plans moving forward. So expand the current study and then also have an offshoot study that will more so focus on these high-risk patients.